Good afternoon, everyone. My name is Durar AlJishi. I'm a second year medical student, and today I'm here with my co-tutor, Sattam AlMezied. Sattam, say hi.
Hi everyone, good afternoon.
And today we're inshallah going to be giving you guys the renal OSPE crash course. We really, really hope inshallah that it'll be beneficial. Inshallah, we've covered everything. Hopefully, but again, do not use this as your main source. If you do have more time, please be sure to go over your lab manuals and your lab slides. Inshallah, we've covered everything from here. But just give me a minute as I share my screen. One second. Can you guys see my screen?
Yep.
Okay, so hopefully we're not crashing out in this vlog. Inshallah, it'll be an amazing and um, successful block, inshallah. Inshallah, filled with nothing but good grades. So, again, as I said, my name is Durar Jishi. Here's my contact information and Sattam's contact information as well. If you guys need anything, please feel free to reach out. So, without further ado, let's begin it. Let's begin. Bismillah. So, first, we're going to start off with the posterior abdominal wall. And we're gonna move on then to the kidney, the ureter, the bladder, just moving on along in chronological order. And then we're gonna go to the urethra, the prostate, and then آخر شيء sectional anatomy. So, posterior abdominal wall. الحين, we've divided the discussion of this into first talking about the lumbar vertebrae and then the muscles and the nerves. So, kind of just like a quick little thing to remember, I guess. You can remember that there are five lumbar vertebrae and five muscles, okay? Technically there are six, بس قلنا five يلا عشان نمشي الموضوع. So, let's start first with the five lumbar vertebrae. So here, you guys, I believe, have taken the other vertebrae, like the cervical vertebrae, thoracic vertebrae, maybe back in FND and CVP. So I just put the slide over here as kind of like a correlation when you're trying to, kind of like, yani, to better modify your understanding, I suppose. But the only thing that's required for you to know is the lumbar vertebrae. So what do we need to know about it? First, if you could see this section over here is called the vertebral body. طيب. What shape is it? You can kind of make it analogous to a kidney. So if they ask you what vertebral body shape it is, it's called it's يعني it has a kidney vertebral body. طيب. What else can we notice about this? Over here, we can see we have something called a foramen. You guys know what a foramen is, صح? It's basically like an opening to something. So how do we describe the vertebral foramen? Here, it's triangular. طيب, it's a large triangular foramen as compared to مثلا when you see the thoracic vertebral foramen, it's more circular. طيب. And there are other points you need to know as well. I wrote them down here. So when we look at the spinous process, طيب, this one over here is the spinous process of the vertebra. Okay, it is short. How do we know it's short? Because when we compare, over here is also the spinous process. How do we know it's short? Because when we compare it to the thoracic and the cervical, this is the spinous process, this is the spinous process, we could see that it's much longer. طيب. We have long and thin transverse processes as well. Transverse processes are these projections that are coming out over here. طيب, this thing over here. As compared to the thoracic, it is شو اسمه it's longer and thinner, okay? We also have nearly vertical articular processes, which in our slides we titled it as superior articular processes. It's not the most high yield thing, but just to know the anatomy of the vertebra, the articular processes are going up, and articular processes are basically assessed and they articulate with the vertebrae that are above them, right? And then, of course, we have transverse process facets and demifacets are absent. So, do you guys remember demifacets and facets from CVP? I hope you guys do. شو اسمه I don't know if you guys are typing in the chat بس شو اسمه حتى أنا when I was working on this pal I forgot that facets and demifacets were a thing but basically they are the articulation processes for إن هما they connect with the what's it called with the ribs, sorry, so it's not our concern for this block but just so you know إن هما they're absent. طيب. Again, these are just reiterations, kind of like color coding things. So we could see this is the vertebral body, the triangular foramen, the vertical articular processes, the spinous process in the back, and the transverse processes here. طيب. And this is also a side view, transverse process, superior articular process, and spinous process. They will, I believe, يعني when I was looking through past questions, and I'm pretty sure we got a question like this as well, there's always one question about the vertebra at least. فمake sure that you know this. Inshallah, it's nothing too hard. Someone's drawing on the screen. Okay. شو اسمه. Before we move on, does anyone have any questions about the vertebrae? Inshallah, it's nothing too hard. But if you guys have any confusion at any point, you guys can let me know. Is everything good? Okay, awesome. الحين let's move on to the muscles of the posterior abdominal wall. So, let's run through them. We have firstly the iliacus muscle, okay? We can see that the iliacus muscle is sitting in the iliac fossa, okay? And it stops at an area of the femur called the lesser trochanter. طيب. We've put the origin and insertion for the muscles in the posterior abdominal wall. It's not the most high yield thing, I would say, but it's just so you guys can kind of get used to the mentality of the block MSK, inshallah, when you guys are gonna take it later in the year. And they do ask about not necessarily origin and insertion, but about the attachment sites. And this also helps you like visualize like exactly how the orientation of the muscles are. It's helpful to know. So here we have the pelvis basically, and this area is the iliac fossa. So hence the iliacus muscle is within the iliac fossa and it connects to it inserts, sorry, into the lesser trochanter. It's innervated by the femoral nerve and its action is hip flexion. Hip flexion is basically kind of like, think of like when you're squatting or when you're sitting down, that's hip flexion. طيب. So, I mean, I already skipped to the other slide, but can any of you guys tell me what muscle the iliacus fuses with? It fuses with another muscle in the posterior abdominal wall.
Psoas major.
Yes, exactly. It's the psoas major. So we can put it into a little equation here. We have the iliacus plus the psoas major is equal to the iliopsoas. Okay, and this makes sense when we look at the psoas major muscle innervation. We can see it's also innervated by the femoral nerve, and it makes sense because the iliacus was also innervated by the femoral nerve over here. طيب. It's innervated by the femoral nerve as well as the L2 to L4 ventral rami. Its action, again, the same one as the iliacus, hip flexion in addition to lateral flexion of the lumbar spine. Lateral flexion is kind of like when you're bending to the side kind of. That's lateral flexion, okay? Its origin is the L1 to L4 transverse processes. Remember, we talked about the transverse processes of the vertebra. It's the projections on the side. So it's attaching to those processes and it's inserting into the lesser trochanter. And we can see that here. They're both fusing to the lesser trochanter of the femur, okay? I hope everything is clear so far. And in addition to that, we also need to note that the lumbar plexus is within the psoas major and it's surrounded by psoas fascia. So why is that important? الحين we need to know, or like we need to understand the fact that all muscles in our body are covered by fascia, okay? Fascia is basically like a connective tissue covering, طيب, and it separates all the muscles, or like all the individual muscles basically. So the clinical correlation of why this is important is الحين when you have fascia surrounding the muscle, okay? And let's say someone gets an infection in that area. You are going to have something called an abscess, okay? I don't know if you guys know what an abscess is, but basically it's when you have an infection in that area and that infection is contained, it's going to be contained by the psoas fascia, طيب? And you can see it here in the CT scan. This is an abnormal like enlargement of the psoas major muscle and it's going to form an abscess, right? So it's a collection of like a contained infection kind of. طيب? And something else, you can also see that there's this muscle over here is the psoas minor muscle. They don't really ask about it, but I just thought I'd put it in here. طيب? وبعدين we have the quadratus lumborum muscle. Quadratus quad. It's basically four-sided. That's how you remember it. It's innervated by the L1 to L4 ventral rami, and its action is also lateral flexion of the spine. طيب. And its origin, we have it in here, the iliac crest, which is over here you can see at the top of the pelvis, and it inserts to the 12th rib. It also attaches to the L1 to L4 muscles, but for the main identification factor, it's a four-sided muscle, and it attaches to the iliac crest and inserts to the 12th rib. Okay. And I also bolded these because I feel like they're more likely to ask about these than they are about origin insertion. But again, know them just in case. طيب. And then آخر شيء we have the diaphragm, which basically forms the roof of the posterior abdominal wall. As we know, it's innervated by the phrenic nerve. Its origin, it has a few origins. We could see over here we have the left and right crura, as well as the fact that it originates in the costal cartilage and the back of the xiphoid process. So we can see the xiphoid process over here. And it inserts into the central tendon. Okay, and this is, I believe, a little bit of a throwback to CVP as well, just to know the diaphragmatic hiatuses, hiatuses. So you have the opening of the diaphragm for the inferior vena cava to come out at level T8, the opening at T10 for the esophagus to come out, and the opening at T12 for the aorta to come out. And we can see in this level as well, it's going from more anterior to, sorry, it's going, yeah, anteriorly to more posteriorly. Okay. And here we can see as well on the cadaver, then we have the quadratus lumborum and the psoas major. Here I think it's more clear. We could see the quadratus lumborum, the iliacus muscle as well. Here you could see kind of the pelvic brim and the psoas major. Okay. And also transversus abdominis. You're gonna take this more in GI, I believe, the anterior abdominal wall muscles, but just for the sake of completion, and no, we have the transverse abdominal muscle. It's yani, yeah, it's a muscle in the anterior part of the abdominal wall, but it kind of starts yani, posteriorly as well. So it kind of makes up the posterior, part of the posterior abdominal wall. And it runs transversely and horizontally, and the innervation is the subcostal nerve. But I don't think they'll really ask you guys about this in this block. Okay, now, yalla guys, time to lock in. I need you guys to help me answer this question if any of you is brave enough. Can anyone read it and answer the question, please? Whether in the chat or unmuting your mic.
Can I read?
Yes, for sure.
Identify structures labeled 4 and 5 and state their innervation. So, one is diaphragm. It is innervated by phrenic nerve. Second is transverse abdominis muscle. And
Yes.
I don't know its innervation. Third one is quadratus lumborum. And fourth one is iliacus. And fifth one is psoas major. Psoas major is by femoral nerve, right?
Yes, psoas major is by the femoral nerve as well as the L2 to L4 innervation. Sorry, yeah, L2 to L4 ventral rami and the femoral nerve. You're right. And then the what's it called? The transverse abdominis. Again, it's not really high yield, but it's innervated by the subcostal nerve. And then you got this right as well. The fourth one is the iliacus, and it's innervated by the femoral nerve. Thank you. طيب, so now we move on. We have the nerves of the posterior abdominal wall. Okay. We didn't get a question like this last year, but I think 16th batch mentioned in Homa they got a question like this and they brought this picture. Okay. It's nothing more than yani, just making sure you know what nerve is what because they're already gonna have things labeled for you. So in an OSPE question, they'll have this exact picture probably if they were to give it to you, and or something similar, and they'll be like identify structure number 4 مثلا. طيب. So we can follow it along here. We see this nerve coming here is the subcostal nerve, which is the nerve يعني, right below the rib, subcostal. Number 2, we have the nerve L1, which is coming from the lumbar plexus. You can't really see the lumbar plexus, but it would be probably somewhere in this region. And then you can see it kind of protrudes here. It's more visible. The L1 nerve. And the L1 nerve splits into the iliohypogastric and then the ilioinguinal, which we can see here in number 3 and 4. And then we have number 5 over here is the lateral cutaneous. Okay. Number 6, we have the femoral nerve. Number 7 over here, the genitofemoral. We could see it's making its way down to the pelvic area. Number 8 is the lumbosacral trunk. And 9 is the obturator nerve. Okay. The nerves in general, I don't think they're super high yield in OSPE specifically, but of course these ones I believe you've taken it in Dr. Olina's lectures, so it's definitely good to know them. And then here is a picture from your lab committee slides as well, or your lab committee, yeah, yani they're pictures where they've outlined it here as well on a cadaver. Okay. Some of the key takeaways, it's important to note that anterior to the psoas major is the genitofemoral nerve. Okay. Which, where did we see it? Sorry. Number 7 here. So this is the psoas major, and this is the genitofemoral nerve. And the lateral to the psoas major, which we mentioned is here, is the lateral femoral cutaneous nerve. Medial to it is the obturator nerve, which we said was number 9. And then again, L1 divides into iliohypogastric and ilioinguinal, which we mentioned was in this area. So 2, and then 3, and then 4. طيب. Now moving on to the abdominal aorta. Okay, so can anyone tell me, الحين when we have the abdominal aorta here, right? What two divisions does it divide into, basically?
The common iliacs.
Yes, exactly. So we have the right common iliac and the left common iliac artery, and it's at level L4. This is very important, okay? They ask about the يعني you're expected to know this in MCQs, SAQs, OSPE, like this is just a fact. And it bifurcates at level L4, okay? And then afterwards, we have it continue to the internal iliac and the external iliac, okay? I already wrote it down here. I kind of spoiled it for you guys. But إنه the internal iliac will supply the pelvic organs, and the external iliac will supply the lower limb, and it's on the same for both sides, on the left side and on the right side. Okay? So yeah, that was the main ones, يعني إنه when the aorta bifurcates, okay? Now we'll talk about the anterior unpaired visceral branches. Are you guys familiar with the anterior unpaired visceral branches and what it supplies?
Yes.
And do you want to point some of them out for me? Or I spoil it for you guys?
We have the celiac trunk in this model, and the superior mesenteric and the inferior mesenteric.
Yes, exactly. So you have the celiac trunk, superior mesenteric, and inferior mesenteric. Good job. Okay. And this is going to be very, very important. Like not just in this exam, but this is something you're also going to carry on with you in the GI block, inshallah. So make sure that you know this, okay? Unpaired visceral, meaning it supplies, when you see visceral, it's basically it's supplying an internal organ, okay? And it's unpaired because it's supplying one organ only. So it could supply the stomach, it could supply the intestine. That's why it's called unpaired, okay? Because you only have one stomach and one large intestine, for example, okay? And again, the levels are at T12, L1, and L3, okay? It's very important for you guys to know this as well, for this block and for the GI block, inshallah. طيب. And now we have the lateral paired visceral branches. So what do you guys think is supplied by paired visceral blood vessels or arteries? They're again like the main branches.
The kidneys.
The kidneys, exactly. The renal artery. Yes,
Yeah.
exactly. طيب. Any more
And
suggestions?
the suprarenal glands.
The suprarenal glands as well. That's true. Any other suggestions? Gonadal, yes. Gonadal as well. طيب. So we have the middle suprarenal arteries, which you're right to know it supplies the adrenal gland, and we have the renal arteries, and we have the gonadal arteries. Okay, these are paired visceral branches because you have two of each structure basically. Okay, and do you guys know what levels they? I think you guys need to know the levels. Yeah. Okay. Again, I spoiled it for you guys. So we have the middle suprarenal. It comes out at level L1. Renal arteries at L2. I think this is the most important, and the renal arteries come out from L2, and gonadal arteries at L3. Okay. And then this is just again for the sake of completion. We have the parietal wall branches, the inferior phrenic arteries at T12. I think if I'm not wrong, these are the inferior phrenic arteries. And we have the lumbar arteries from L1 to L4 and the middle sacral artery. These are not really important. They might be important later on though. The middle sacral artery, it's supposed to be here. Like it's just like a small branch that comes out here. But yeah, not very high yield, but it's just for the sake of completion, يعني. طيب, again, time to lock in you guys. So this is an aortography, I'm pretty sure it's called. Does anyone want to help me label the arteries that are here? They're the main branches of the arteries that we just discussed. Let me see the chat. Okay, one is the abdominal aorta, yes. And it bifurcates into what arteries? Yes, the common iliac artery. Good job, you guys. And then so you have the right and then the left. Okay. Number three. Again, I just said the notes wasn't really high yield. I'll Okay. Let's see if you guys can get it. Number three. What do you guys think it is?
Lumbar arteries.
Yes, it's the lumbar arteries, exactly. بس okay, it's not هو فعلا it's not really high yield, but I forgot that this question existed, you guys, my bad. So since it's actually a question and it's part of your objectives, this picture is in your slides أصلا, so you should know it. This one is the lumbar arteries just as an identification point. And then number four and five. Four is internal iliac artery, yes. And number five, you have internal, and then number five is the external iliac. Exactly. Good job, you guys. طيب. Now we finished with the aorta. Let's move on to the IVC. Okay. So it's the same mergy. So you have the vessels are draining into the IVC. Over here, let's look at it. So we have the right common iliac. Oh, this is a typo, guys. My bad. It's supposed to say iliac vein, not artery. But so now you have the right and the left common iliac are draining into the IVC, and then you have the right renal vein is draining into the IVC, and the left renal vein is also draining into the IVC. طيب. What drains into them as well. This is a very important thing to note. In the right gonadal vein, which is like the which is the right testicular or the right ovarian vein, is draining directly into the IVC, whereas the left drains into the left renal vein. طيب. And I'm gonna come back to this point in a second. وبعدين we have the right suprarenal vein also drains into the IVC, and the left suprarenal vein again drains into the renal vein. Okay, so everything is draining into the left renal vein before it enters the IVC. تمام? And so why is this important? Are you guys familiar with the varicocele veins? Are you guys familiar with this concept? طيب. So, can anyone explain it to me really quickly? It's not super important in OSPE, but I think it was taught to you guys in labs, and it was probably taught to you guys as well in the lectures. Yes, exactly. It happens when there is compression of the left renal vein. طيب. So as we said, the left gonadal vein drains into the left renal vein. Okay. The left testicular vein drains into the left renal vein, and this will cause naturally an increase in venous pressure. Why? Because we can see aslan and it's coming from the pelvic area and it's going up at a 90-degree angle. So there's already high pressure from this because of this. Okay. So when you have something like nutcracker syndrome, it will cause which is basically the compression of the left renal vein between the aorta and the superior mesenteric artery. This will increase pressure more and it will cause more backflow, which results in varicocele veins. And so it's more common to happen in the left side because of its anatomy. And the left renal vein the left gonadal vein will drain into the left renal vein. تمام? Yes, and the papilliform plexus as well. That's what's that's what's being that's what's expanding. It's the papilliform plexus, which is connected to the gonadal vein and then the left renal vein. Yes. طيب. And this is what it will look like as well. Okay, time to lock in once again, you guys. Can anyone read this question and answer it for me, please? Anyone, a brave soul, maybe? Yes, the green is the psoas major. Okay, I'll read it really quickly. Well, I showed the answer again. طيب. Identify the structures of the green and red arrows. So someone said in the chat and notes the green the green is the psoas major indeed. And then the red is the left gonadal vein. This red arrow over here, it's the left gonadal vein. So you can see it's coming from the pelvic area and it's going up into the left renal vein. تمام? So this is the left gonadal vein. Okay. Next question. Does anyone want to read? Anyone want to read? طب I'll read and then you guys can type your answers in the chat. Identify the marked structures and their levels. Anyone want to try this out? So this one over here is A, and this one over here is B. Um, A is the left renal artery at L2, yes. And B, do you guys know what B is? Is the inferior mesenteric artery at L3. Yes, you guys are correct. Good job. طيب. Now, الحين we're moving on to the kidney. But before we do so, does anyone have any questions about the posterior abdominal wall? Is there anything that was unclear? Anything that you guys want me to explain again? Inshallah, everything was okay. Hopefully, it's not too much. Are you guys good? خلاص تمام. I'll take that as a yes. And of course, if you guys have any questions along the way, you can always يعني, text in the chat or text me after the session, inshallah. طيب, moving on to the kidney. Okay, here we're going to talk about kidney and the ultrasound. So, the star of the show is the kidney, of course. Okay, so does anyone want to list out to me really quickly functions of the kidney? Why is the kidney so important? What's all this fuss about the kidney? Why do we need it? It removes waste, acid-base balance and electrolyte balance, yes. Filtration waste products, pH balance, yes. Filtering the blood, yes. You guys got it basically. So, one second. Okay, so it again helps filter toxins and excess water. It regulates electrolytes, so we have like secretion and excretion of different electrolytes. It maintains acid-base balance, and it also secretes renin, which helps regulate the blood pressure. Okay. So let's look at the gross structure. Like let's analyze this يعني, step by step, okay? Here we have the main organ, which is the kidney, okay? We can see and we have three structures that are entering and exiting the kidney, okay? We can like denote this as VAP, okay? This is how you memorize it. You have the vein, which is the renal vein, it's entering, and it's exiting. The renal vein is exiting, and you have the renal artery, which is entering, and you have the pelvis, okay? The pelvis is basically the renal pelvis, it's the what leads to the ureter, as you guys know, okay? So VAP is very important. Why? Because it helps يعني anatomically it's important. I mean, why? Because it helps us differentiate between the right and the left kidneys, okay? So if they ever bring you a question where it's يعني requires you to know whether it's the right or left kidney, the renal vein will be the most anterior, okay? And the ureter here or the pelvis will be the most posterior, okay? These structures also make up the hilum of the kidney, okay? And they contain hilar fat and lymphatic tissue that surround these structures. When I say hilum, do you guys know what hilum means? Pelvis or ureter? It's the pelvis basically, but no, the renal pelvis it leads to the ureter. So kind of like the very, very beginning, if you guys can see here. Uh, well, it'll be more clear in the next slide. But no, it's at the very, very beginning, it's called the renal pelvis, okay? And then it leads to the ureter, which is down here, okay? Do you guys know what I mean when I say hilum? Yes, exactly. It's the opening to the renal sinus. Exactly. So, let me check one second. Yeah, for the person who is asking, this is basically the renal pelvis in this area, okay? And then it goes to the ureter, okay? So when we say the hilum, you guys can kind of think of it as like a doorway, okay? You guys probably took the hilum of the lungs as well in back in CVP. The hilum is basically kind of like a door, and it's the entrance where يعني the different structures enter and exit, okay? بعدين, the renal sinus is basically the internal space where that hilum leads to. So whenever you hear the word sinus, sinus is basically like a space, okay? So you see like these areas here, these are all spaces, but they are filled with the structures, if that makes sense. So like we said here, it's gonna be filled with the renal sinus will be filled with hilar fat. It will be filled with the renal pelvis and the calyces, which I'll talk about in a second. And it also helps separate the structures from the medullary tissue. Okay. And it's also important to note again in the the hilum is at level L1. Okay. Let me check the chat one second. Someone asked, is that an abnormal kidney? No, it's not. This is I got this from a textbook. This is like what the kidney actually looks like. But maybe على أساس إنه it's very, I don't know, a very like detailed artistic artist person. طيب. Yes. تمام. And then this is just like another kind of like way to like view this. When I was talking about the hilum and the renal sinus is going to be filled with the hilar fat, okay? And then there's going to be structures entering and exiting, like the renal pelvis and the calyces are going to be here as well. And then the hilum is just the opening. Tamam? I hope that's clear. I hope I didn't overcomplicate it for you guys. Let me know if you guys didn't get it. But basically, the hilum is the opening, and the renal sinus is the area that's inside, essentially. Tamam? Now, to cut the kidney open, okay, I want you guys to kind of visualize the kidney as if it's like an orange, okay? We have the outside of the orange, and then we have the wedges inside, okay? Same thing with the kidney. We have the outer layer and the inner layer, which you can kind of, make it analogous to like orange, like pieces or wedges, tamam? So, here we can see that the main two parts of the kidney is the medulla and the cortex, okay? So the cortex is the outer layer of the kidney and the medulla is the inner layer. You'll see that the medulla is darker, it's the inner region, and it contains renal pyramids, okay? The renal pyramids are basically where the urine, or like like all the fluid, the urine and whatnot, it's going to be filtered and it's going to go into these areas, okay? Like it's gonna, it starts from here and then it'll go down from here, okay? And then the cortex is the outer layer. It's the region that's lighter in color, and you have something called renal columns. So you can kind of see in the orange here that, if we can imagine this like as a kidney, and the outer layer is the cortex, but you also have regions like the white part of the orange. Um, I remember when I was eating oranges growing up, and I didn't really like it. It's kind of like the pieces that I would pick off, but that's exactly what it is. And it's dividing the orange pieces, okay? You can kind of see that similarly here with the kidney, and then you have the outer part, okay? And then you have the inner part that's dividing it, just like an orange, okay? And this area over here, like that's dividing it, is called renal columns. So it extends into the medulla and it separates the renal pyramids, okay? And what to know about this is that when you have a renal pyramid, which is this area of the medulla, and the renal cortex, you put it together and it becomes a renal lobe. And so you have about 7 to 18 lobes in like one kidney, basically. Okay? And then, as I said, الحين when we're filtering the urine, we start off from the medulla, and then it will drain into a structure called the minor calyx, okay? It's going to collect urine from the renal medulla, and the tip of it is called the renal papillae, which we're going to get into in the histology portion. And then the minor calyx will drain into the major calyx. So you have 2 to 3 major calyces that will then drain into the renal pelvis. So again, this area over here, you have so you have the tiny minor calyx, minor calyx, minor calyx. It's going to drain into one major calyx, and then a major calyx over here, major calyx over here, and then it drains into the renal pelvis. Tamam? And then it'll travel down through the ureter. Okay? So this is again the order: renal papilla, minor, major calyx, renal pelvis, and then the ureter. Tamam? Is everything clear so far, you guys? Okay. So, how does the kidney take care of itself? With blood supply. That's how it's going to get its nutrients, right? So, the blood supply, I didn't really get into it this much, like in the sorry, for this presentation, I didn't really go much into the blood supply of the kidneys. I know that Dr. Olena did talk about it, but I don't recall seeing any past questions that are very relevant in concerns of the renal blood supply. But what you guys do need to know is the difference between the left renal vein and the right renal vein. So, can anyone tell me what the difference is? And yeah, like its clinical correlation, I suppose. I think we kind of talked about it before, but um, yeah, the differences basically. Yes, exactly. The left is longer. One second. You're right. The left renal vein is longer. طيب. One second, you guys. Okay. So, it's longer. Why? Because we can see that the inferior vena cava over here is on the right side. Okay, so when it gives off its branches, it's going to give to the right renal vein and then the left renal vein on this side. Okay, it's going to cross over the abdominal aorta, and that's basically why it's longer because the IVC is on the right side. And then, like we talked about earlier, we're going to have we can possibly have nutcracker syndrome where the superior mesenteric artery and the aorta compress the left renal vein. Yeah, that's it. طيب. And then here are some pictures we can see. They might ask you guys to know it from a cadaver. I'm sorry, the labels aren't really clear over here, but on this side, you could see there's the inferior vena cava. Okay, it gives off the right renal vein and the left renal vein, and you can see that it's crossing over the aorta. تمام? And then we have the aorta, the bifurcation, all of that. Okay. So, where does the kidney live? The kidneys are located retroperitoneally. Do you guys know what I mean when I say retroperitoneal? Like, what does it mean that the kidney is located retroperitoneally?
Behind the peritoneum.
Behind the peritoneum, exactly. So, just to put it into perspective, the peritoneum is basically a sheet of connective tissue that is covering different organs, okay? Like a bunch of your internal organs. But this does not apply to the kidney because when the way that you guys are going to take this in more detail in GI, inshallah, a lot of this is connected to GI. But the peritoneum, basically, it goes like this is the kidney, and the peritoneum goes and it covers the kidney. Okay, so retro means behind, so it's located retroperitoneally. Okay, and it rests on the posterior abdominal wall. Here we could see there are some of the muscles, and it's placed obliquely. It's placed obliquely means it's placed on an angle. Okay, so the kidney is kind of like resting backwards on an angle, you could say. Okay, and of course, it's located between the vertebrae T12 and L3. The peritoneum, I might. I don't think the peritoneum might be this yellow thing. I don't want to شو اسمه say something wrong, but I think it might be the yellow thing. It will hopefully be put into more perspective in the GI block. Because Dr. Paul, I think, gives a lecture on it. The white line, I'll get into it. The white line is one of the three coverings of the kidney. I'll get into it in a second, but I believe this yellow line should be considered the peritoneum, I believe. طيب. But the white line is not the peritoneum. Yes, exactly. It's the capsule. I'll get into it in a second. طيب. Whoopsies. Okay. Uh, and we have also these muscles over here. We have like we talked about it a few minutes ago, the psoas major, which is posterior-medially located or related to the kidney, sorry. And then over here we have the quadratus lumborum. So just to connect the dots here. Okay. طيب, who are the neighbors of the kidneys? We need to know the different relations to the kidneys, and they're different from the right versus the left. So let's see. We have أول شيء the right kidney. The anterior relations, they go superior to inferior. We can see them here. So both kidneys have adrenal glands or suprarenal glands. Okay, so that's the first thing that's going to be related to it over here on top. Then we have the liver, which is located in this area. And we have the second part of the duodenum. طيب. And then the right colic and the right colic flexure is part of the large intestine and the small intestine over here. These are not very important. What I would say is the most important is probably the first three. We got a question about this last year. You guys will probably see it in a second. But these three, I would say, are the most important ones. Above is the suprarenal gland, then we have the liver over here, and the second parts of the duodenum, which again are going from superior to inferior. Okay, and we have to note as well that the right kidney is going to be 2 to 3 centimeters lower than the left kidney because of the liver, right? We said the liver is on the right side and it does take part of the kidney as well. And so it's part of its anterior relation, yani. And so it will be 2 to 3 centimeters lower because of that. And in addition, you're going to have the superior pole. The superior pole, yani the superior part of the kidney basically will be protected by the 12th rib I don't think I have a picture of it, but the 12th rib will be behind superior part of the right kidney. Okay. And then we have the left kidney, again, going the anterior relations, going superior to inferior. The most important ones, again, I would say are the suprarenal gland. We have the spleen over here on the side because the spleen is on the left side. Okay, that's also very important. And the pancreas over here. طيب. Left colic flexure, jejunum, these things are more related to GI. I don't think they'd ask you about them, but the ones highlighted in purple are most important. طيب. And then again, because the left kidney is slightly higher than the right kidney, it's going to be protected by the 11th and 12th rib. Okay? So, how is it stabilized? So, this is for the person who was asking about the white covering of it. We can see here in this picture, there are three layers of tissue, okay? The first one is the fibrous renal capsule, okay, which is basically it's basically a sheet that's stuck on the kidney, okay? And it's like very difficult to rip off. It's يعني part of the kidney itself, أصلا. Okay, and it completely covers the kidney, like I said. The second layer you're going to see is the perinephric fat, okay? Which I need to note as well that it's different from the hilar fat. If you guys remember from the previous image here, we are going to see hilar fat. Like within this area, within the renal sinus, there's going to be hilar fat, but it's not the same fat that is the one that's covering the kidney. The one that's covering the kidney is called perinephric fat, okay? And then آخر شيء we have the renal fascia. So this is the outside layer of it, the third layer. And it's a thin layer of dense connective tissue and it holds the kidney in place and it anchors the kidney to the posterior abdominal wall. Okay. I think Olena probably mentioned this in her lecture as well, but it's the same concept as as if you guys remember قبل شوي I talked about the psoas abscess. So when there's an infection and you have the fascia is going to contain the infection. It's the same thing here, and you have the fascia is going if there's an infection in this area, like in the fat or in the kidney, it's going to cover sorry, the renal fascia is going to contain the infection within itself, يعني. Okay? Now, once again, time to lock in, you guys. Can anyone read this question for me, please, and answer it? Anyone brave? Or in the chat? Okay, so name two muscles and two nerves that run posterior to the structure. Yes, so someone said psoas major. Yes, psoas major and quadratus lumborum, and the nerves are iliohypogastric and ilioinguinal. Yes, you guys, good job. If you guys, I kind of wish I had a picture reference, but then no, if you guys, oh yeah, I do, hello. Okay, here we have the psoas major and we have the quadratus lumborum, okay? And if you guys remember as well, we said the L1 will branch into iliohypogastric and ilioinguinal, and that is, and the lumbar plexus is within the psoas major. So those two nerves are like posterior to the kidney, tamam? Okay, next question. This is the question that I was saying that we got last year about it. Can anyone answer it for me, please? Okay, the green is liver and red is the second part of the duodenum. Exactly. I don't remember actually what I put in this, but it was not the liver or the second part of the duodenum, so just be careful, you guys, for this question. And for the second part of it, identify the embryological origin. It's the metanephros. Exactly. Good job, you guys. So they can bring embryo in OSPE. I think this was the biggest shock was that they brought embryo in the OSPE. So just يعني, be mindful of that, tamam? Okay. Next, we're moving on to the ultrasound. Okay. So in brief, basically, the way that the ultrasound works is, it's a non-invasive method of, يعني, kind of like looking at what's happening inside your body live. So, مثلا in pregnancy, we can see they use ultrasound because it's non-invasive, and you can see exactly what the baby is doing. It's kind of like yeah, like it's self-explanatory, and you could see it, tamam? So we have three things that we need to know, and I think ultrasound will be covered again in your future blocks for other organs. So it's important that you guys should know like how this works as well. Is you have the black color, like when you see on the ultrasound, when it shows black, it represents fluid, and this is called anechoic, okay? When it's gray, it's basically soft tissue, which is hypoechoic, and then the white or yani, the lighter gray areas are hyperechoic, and you have things like stones, ligaments, tendons, bone, and this is why yani, ultrasound is very important across yani, a lot of methods. Sorry, one second. Um, someone asked a question here, sorry. This is the okay, sorry guys. This is a problem in my labeling. Someone asked how is it the liver if it's the left kidney? This is a problem in my labeling. I'm gonna change it inshallah. This is meant to be the right kidney. Tamam? That was my mistake. Sorry, you guys. But for the right kidney, it's the liver and the second part of the duodenum. طيب? Okay, so let's move to the ultrasound. الحين for the ultrasound, they're always going to give you the same picture, okay? Let's look at this picture, for example, okay? We'll flip the kidney to the side and let's start comparing. So we have the first part is the renal cortex. It's very simple, inshallah. You don't need to know much about it. Just over here, be able to identify that this part is the renal cortex, okay? Really, renal cortex over here and renal cortex over here on the outer edge, tamam? Then we have the renal column, which, like we said earlier, is the thing that divides it divides between the sorry, it divides the renal pyramids, okay? So we have this area is the renal column. Then we have the renal pyramid, or renal pyramid, medullary pyramid, and again, what did we say um the like when we see it's black, طيب. Why is it black? Because it has fluid, right? So the renal pyramids, طبعا they're gonna have fluid because they're filtering the content that's inside. Okay? And then we have the renal pelvis and sinus fat, which is going to be in this area. Okay. So this is the exact picture that they're always going to give you. Inshallah, they're not going to change it. خلاص. يعني when it comes to ultrasound, the pictures are like pretty much set. Okay. So again, we have one more time the renal cortex, number two, the renal column, number three, the medullary pyramid, and number four, the sinus fat. And again, we can see that it's more hyperechoic. Why? Because yani fat is pretty dense. بينما here we can see in number three, the medullary pyramid is going to have fluid. That's why it's dark. Okay. So up until this point, does anyone have any questions at all? The capsule is hyperechoic. I don't know if it's considered, one second. Hyperechoic, probably شو اسمه hypoechoic, I think. It's kind of maybe somewhere in the middle because it doesn't look if you look in the picture, it doesn't look super dark, but not super light either. I think it would be hypoechoic. And then sorry. Yes, the ureter is most posterior, so it should be the left. Yeah, it is the left kidney. Again, guys, sorry about that. There was a mistake in the picture. It should be the right kidney, and because the pelvic thing is yani, if we could go back to the picture. Uh, the pelvis you can see here is most anterior. Um, دقيقة. Guys, I'm sorry, في خلل بالpicture. I'm so sorry. Before we send this to you guys, I'm gonna change the picture. Inshallah, it'll be more clear. Um, it'll be more clear, inshallah. Sorry about the confusion for that, you guys. بس شو اسمه, do we have any more questions? I hope no, I'm being clear. If you guys don't understand anything, like feel free to stop me. Yeah, it's hyperechoic. تمام. Okay, خلاص. I'll move on. Next to the histology portion. Okay. So over here we can see a nephron, right? Can anyone remind me what the different parts of the nephron are? Because this is going to be the segue into the histology section, and then we'll be done for the kidney. طيب, let's start. These like arteries over here. Can anyone tell me what these are? Yes, the glomerular capsule, exactly. So we have the afferent arteriole and then the efferent arteriole, okay? Then on this side, what are these tubules called? These tubules versus these tubules. Okay, well, I spoiled it for you guys again. Yes, the proximal, exactly. And then the distal tubule, yes, and then we have the loop of Henle over here. And then the last thing is the collecting duct. Good job, you guys. طيب. So let's start. الحين for the kidney histology, again, previously when I told you guys about the anatomy of it, hopefully it will be clear now to present the histology of it, okay? So in this histology slide, I think Dr. Ani said this is the kidney of a mouse. So this is essentially one lobe of the kidney, okay? But it's anatomically similar to the human kidney, okay? So let's start. الحين احنا we have on the outside we have the renal cortex, which like we said was the outside portion of the kidney, and it contains cortical lobules. What are cortical lobules? They are made of medullary rays, which you'll see them as straight, and cortical labyrinth, which will appear as circular structures. Okay. And then on the inside, you have the medulla, which is the middle portion. Okay. It's going to contain medullary and papillary collecting ducts of Bellini, as well as the loop of Henle and the vasorecta. So we're going to get into that now. الحين, so like I said, the renal cortex will have the cortical lobules. You can see that there's the cortical labyrinth over here and the medullary rays over here. They're going to appear as straight lobules, or sorry, straight rays versus the cortical labyrinth, which will appear more circular. So the cortical labyrinth, we can find there is the renal corpuscle, which is the same thing as يعني إنه it has the glomerulus and Bowman's capsule. In relation to it as well, like I said earlier, شو اسمه, in the ultrasound, they won't give you any pictures that are different, and it's the same thing with histology. They're always going to give you guys the same photos that they give you. So just make sure you know the photos really well, or like the histology slides really well. تمام? So here we can see in relation to it, we have the proximal convoluted tubule over here. Again, this is on the cortex طيب. We have the proximal convoluted tubule over here, which will appear fuzzy and pink in appearance, okay? And then over here, we have the distal convoluted tubule, which in contrast is not fuzzy and it's more blue, okay? So these are like this is how you can differentiate them, okay? For the proximal convoluted tubule, they are lined with simple cuboid epithelium with microvilli, which is why it's so fuzzy. And then the distal convoluted tubule will have simple cuboid epithelium without microvilli, okay? So, moving on to the medullary rays. Again, we're still in the cortex, okay? In the medullary rays, it's made up of the cortical collecting ducts, okay, which we can see are white in appearance due to the principal cells, okay? And pars recta, I think hopefully you guys already know this. In pars recta, I think Annie probably explained it, Dr. Annie. In pars recta means straight, okay? So these are where we're gonna see the proximal convoluted and distal convoluted tubules as straight, okay? So the pars recta of distal tubules, we're going to see them as not fuzzy and bluish in appearance, okay? We can see them over here. Oops, okay. And the pars recta of the proximal tubule are going to be fuzzy pink in appearance over here, okay? طيب. The cortical collecting duct, again, they're all going to be lined with simple cuboid epithelium, I believe. The cortical collecting duct is going to have simple cuboid epithelium. Same with the pars recta, simple cuboid, as we mentioned earlier. And again, proximal will be lined with simple cuboid with microvilli. So it's just like we said over here. It's the same thing. It's just in Homa, they're in different regions. Okay? I hope this makes sense. One second. Okay, wait. We said the purple, yes, it's like the distal tubule. We said the proximal tubule is, wait, sorry, wait, I don't think I saw a question in the chat. I don't think I understood it. Let me read it again. The purple is descending while pink is ascending. I'm not sure صراحة. Sattam, can you double check? Because I don't want to say anything wrong. Someone asked this question in the chat. If you could check that, please. I don't want to say anything wrong. Sattam will confirm.
It's not about descending or ascending. It's about being the PCT or the DCT. That's what's most important.
Yeah,
they
exactly.
could be going in any direction.
Yeah, that's true. It's the loop of Henle, you'll see it. يعني it's ascending, descending. But yeah, no, it's not very important. Okay. طيب. فيا again, we covered the pars erecta of the proximal and distal. They're made up of the same epithelium as we said here. It's just to note they're in different regions, okay? طيب, can anyone help me identify the structure over here, this pink one? It's the proximal convoluted tubule. Let's see. Okay. And yes, you guys are correct. طيب. Number 2, can anyone help me identify this one? The renal corpuscle. Exactly. طيب. And then number 3, over here, this region. The pars recta of the distal tubule. That is correct. And then the last one. Oh no, I thought there was one more. Never mind. Tamam. Yeah, same things that are outlined in this region. Okay? Good job, you guys. So, next, moving on to the renal corpuscle. Okay, again, like we mentioned earlier, it's basically made up of the Bowman's capsule, which is the area that will contain the urine over here, and the glomerular capillaries, okay, which have blood. It's very important to differentiate between this, okay? So, first, number 1, we have the podocytes. The podocytes are basically the filtration, they have slits that help with filtration, okay? So, you'll see in this area over here, this space is going to be filled with urine, okay? And this area is going to contain blood vessels. So there are slits for the filtration, okay? Number 2 over here, we can see on the side, and it's lined with simple squamous epithelium, which is the parietal epithelium of the Bowman's capsule. Number 3, like I said, we have the Bowman's space. And then number 4, we have, one second. Number 4 over here, we can see, there's the pars convoluta of the proximal tubule. And then number 5, we have the glomerular capillary bed, which is in this area. Or yeah, you can see here, there's the afferent, and then the glomerular capillary bed, and then the efferent arteries, okay? Or wait, did I label this wrong? لا, okay, تمام. طيب. And the next thing we have is the juxtaglomerular apparatus, okay? So there are 3 parts to it, okay? Or 2 parts, basically, sorry. The أول شيء is the macula densa, okay, which is dense, tall, simple cuboidal epithelium, okay? And then we have the juxtaglomerular cells, which are modified smooth muscle cells that act as baroreceptors and secrete renin, okay? So again, secreting renin, this will influence the blood pressure. If you guys can see the electron micrograph as well over here, we can see there's the juxtaglomerular. I can't speak today, sorry, you guys. The juxtaglomerular cells, okay, they will have renin granules because they secrete renin. And here we can see in the electron micrograph as well, the macula densa, okay? It's important to know the electron micrograph because sometimes they will bring, again, the same pictures and they will ask you, like you'll be expected to know what it is, okay? And then the extraglomerular mesangial cells or the Lassie cells, they're parasite-like cells. They're between the macula densa and afferent arteriole, and it transmits information between the macula densa and the afferent arteriole. تمام? طيب. Next, moving on to the medullary collecting duct. Okay, so this is going to be in the medulla area. So you'll have simple cuboidal epithelium, white cytoplasm appearance, which are the principal cells, and its function, of course, is water absorption due to the secretion of ADH. Okay, location again, it's going to be in the medulla region of the kidney, and it's eventually going to form the papillary collecting duct of Bellini, which we'll see in this slide. Okay, at the end over here, we have the renal papillae. And if you guys remember, I mentioned the renal papillae is the last portion of the kidney, which will drain, or sorry, the last portion of the medulla, which will then drain into the minor calyx. Okay, the papillary collecting duct of Bellini is made up of simple columnar epithelium with short microvilli. Okay, and then columnar cells are also found here. And they're called principal cells or light cells, and they give it and they appear with white cytoplasm again. Okay, yeah. طيب. We can also see there is the thin loop of Henle. So I believe here is the thin loop of Henle, and we can also see, according to Dr. Annie, we have the U-turns as well. So the loop of Henle is most apparent in the renal papilla. Okay. One second. Do we have to differentiate between cortical and medullary collecting ducts? Yes, you do, because in Nahoma they're different slides. Okay. Sorry about that. شو اسمه. So we have, like I said, the thin loop of Henle, which is made up of simple squamous epithelium, and there are no erythrocytes here. Okay, you shouldn't be able to see blood أصلاً. But on the side over here, you will see the vasorecta. Okay, the vasorecta are basically like the blood vessels that are present here in the kidney. So they are straight blood vessels that run parallel to the loops of Henle, and they contain simple squamous epithelium or endothelium, and erythrocytes are inside. So if you see blood vessels, then they are not the loop of Henle. That's basically what you can get from the slide. And it's a combination of straight arterioles and straight capillaries and straight venules. Okay, so anything that you see erythrocytes inside, these are considered the vasorecta. Okay, tamam. We're almost done, inshallah. So we have the minor calyx. Not much about it was mentioned in your lab manuals, but you could see that you have the renal papilla and, oops, sorry. There's the renal papilla, which drains into the lumen of the minor calyx, and there is transitional epithelium present here as well. طيب. And the papillary collecting ducts of Bellini and the white principal cells, which are made up of simple columnar epithelium with short microvilli. تمام. It's important that you guys differentiate between the types of epithelium in each region of the nephron as well. Okay, so we have the filtrate is basically exiting from here. The papillary ducts of Bellini, they're draining into the lumen of the minor calyx in this area. Okay, and then you have the renal papilla over here in this region. تمام. طيب. And the wall of the minor calyx made up of transitional epithelium. Okay. And then the last thing for the kidney, I believe, is the blood supply. So you're going to see that there are, again, I didn't really go into this for the OSPE because it's anatomically, it's not very high yield, but for the OSPE specifically, you guys should know it for your lectures, but for your OSPE, it's not super high yield. But for the شو اسمه, for histology, you should know it. So you should be able to identify you have the arcuate arteries and they run in an arc between the cortex and the medulla. Okay, so you can see that here in these areas. The interlobular artery, which are the cortical radiate arteries, they radiate up into the cortex from the arcuate arteries. And then you have we can see the I can't speak, you guys, sorry. The interlobular radiating arteries over here in these areas, here and here. And then you have the afferent arteriole, which are branches from the interlobular artery, and it enters the Bowman's capsule to form the glomerulus. And we can kind of see that when we zoomed into the glomerulus here in these areas, okay? طيب. And then شو اسمه, like I was saying, the afferent arteriole, it branches from the interlobular artery and it enters the Bowman's capsule. And the efferent arteriole, it's what exits from it. In the cortex, we have the efferent arteriole forms the peritubular capillaries, which are around the convoluted tubules, which again is for the absorption and secretion and all of that. And near the medulla, it continues down to form the vasorecta. Okay, so the proximal convoluted and distal convoluted will have yes, so the proximal convoluted and the distal convoluted will have the peritubular capillaries surrounding it, and the loop of Henle will have the vasorecta near it. Okay, I hope that's clear. Okay, so that is it for the kidney section. My last part is going to be the ureter, but before we move on, do any of you guys have any questions? Anything that you guys are still unsure of? I hope everything was clear, inshallah. خلاص يلا. We'll move on to the ureter. Okay, so before we talk about the ureter, let's quickly talk about the pelvis. Okay, so the pelvis has two parts to it. We can see over here that the pelvis it's composed of like when we divide it anatomically, it's composed of the true pelvis and the false pelvis. Okay, so the true pelvis is over here below the pelvic brim. It's going to be in this area, and the false pelvis is within the wings of the pelvic bone. this part over here, okay? And you can't really see it, but over here you have something called an obturator foramen, and it's going to be more relevant later on where you have vessels entering and exiting that area, okay? شو اسمه so in regards to the ureter again it connects the kidney to the bladder, okay, and it performs peristalsis to transport the urine, okay, and it's divided into three parts. We can see in this part, in this region over here, we have the abdominal ureter. Over here, we have the pelvic ureter. And over here, we have the intravesical ureter. Okay, and I mentioned these why? Because we have three constriction sites for the ureter. Does anyone know what these constriction sites are called? Anyone want to unmute their mic or share in the chat? The ureter pelvic brim, and the wall of the urinary bladder. Exactly. So we can see them here in these slides. There are three constriction sites, okay? The uretero-pelvic junction or the pelviureteric junction, which is basically the area where the renal pelvis continues down as the ureter. So here we have the renal pelvis, and then there's going to be a junction, and then it continues as the ureter, okay? Then we have the area of the pelvic brim. We can see here notes in contact with the iliac vessels as well. And then we have the uretovesical junction, which is the area where it enters the bladder. Okay. And again, the first junction is at L1. The second one is at the level of the sacroiliac joint, like I mentioned, and the last one is at the level of the ischial spine, which is part of the what's it called? Part of the pelvis over here. Tamam? Okay, so why are these constrictions important? They are important clinically. Does anyone want to share what they know about the clinical significance of the constriction sites of the ureter? Yes, kidney stones, okay? So what happens is something that can happen is renal colic pain, okay? So what happens? Sorry, guys, technical issues. I feel like a lot is going on. Sorry about that. Okay, so basically, when you have kidney stones, okay, they can get kidney stones form first of all when there is high concentration of salts, okay? It'll eventually over time it'll form a stone, okay? And these stones can get lodged into like either the kidney or at the different constriction sites, okay? And this will cause renal colic pain. The pain caused by the contraction of smooth muscles of ureters due to kidney stones. طيب. And this will, the clinical correlation here is that it'll cause something called renal colic pain, like I said, and there is referred pain, okay? Pain is referred, it's called from loin to groin, okay, which is the cutaneous area supplied by the genitofemoral and ilioinguinal nerves. So when you have pain, sometimes like the concept of referred pain basically is if you were to have, for example, a stone in your ureter, when it gets kind of like when the brain is trying to like translate the messages and the stimulations that it's receiving from different parts of the body, it'll be shared by both the nerves that supply the ureter and by the nerves that supply the cutaneous area. Okay, so that's what it means basically. So you'll have pain because of you'll have the pain basically because of the fact that you have a stone in your ureter, but it will travel through the cutaneous area supplied by the genitofemoral and ilioinguinal nerves. So that's where the pain is going to appear, okay? Because there is a stone in your ureter, tamam? And the mechanism referred to the cutaneous area supplied by the same spinal segments, which are T11 to L2 that supply the ureter. So it's going to be shared, and when it's when your spinal cord and when your brain like receive this information, it's going to translate this pain to what you feel in the groin area basically. The loin to groin area. تمام? طيب. Again, what to know about the ureters? They originate at the L1 level. It runs along the anterior. It runs anterior along the psoas major. I think we mentioned this earlier, and this crosses the bifurcation of common iliac arteries, like I mentioned. طيب. Something to note as well, in males, the ureter is going to run below the vas deferens, okay? And in females, it's going to run posterior and inferior to the uterine artery. And I'm pretty sure this concept is brought up again in future blocks. The fact that the ureter is below the uterine artery is very, very important because when you have, if a woman were to have something called the hysterectomy, which is basically a procedure where you're removing the uterus, it's very important to not accidentally damage the uterine artery for it to be confused for the ureter, okay? And the ureter, its blood supply is not, like it doesn't have its own like fixed blood supply. It basically takes blood from any vessel that's near it. So it can be supplied by the abdominal vessels, which you can see the renal, the gonadal, abdominal aorta, and the common iliac arteries. And you have the pelvic vessels as well. So there's the inferior vesical vessels and the vaginal artery. Okay. And as for the venous supply, it's supplied by the internal iliac vein. And for innervation, like I mentioned earlier, you have autonomic innervation from T12 to L2, which again is related to the concept of referred pain, and the pelvic and splanchnic nerves from S2 to S4. Okay? طيب, inshallah, we're almost done, you guys. After this, I think it's just the histology. But for now, can anyone answer this question, please? You can read it and answer it. Okay, طب I'll read it. Identify the structure and be very specific with your answer. Yeah, there's the green arrow. And identify two arteries that supply the structure. So the structure, people are saying, it's the left ureter, the left pelvic ureter, yes. Um, or it should be called I think the left ureter is fine. Um, because if you call it the pelvic ureter, yeah, the pelvic, I could be wrong. I actually don't want to overthink this. طيب. The gonadal and suprarenal arteries, tamam. Yes. The left pelvic ureter. Okay. My brain is like in so many places right now. Sorry, you guys. طيب. And then B, the left internal iliac arteries and the gonadal arteries. That's correct. Good job. Tamam. And then the last thing over here we have are just the radiology. We have the radiology images and then the histology. طيب. So here we can see if you look at the radiology image over here, you can see and it's outlined by the yellow line, okay? And these are the ureters, okay? They are lateral and they're on the lateral border of the psoas major. And you must be able to see these because the kidneys are obliquely placed following the pattern of the psoas major muscle. طيب. And then in this picture, we could see that here we have a white circle, which is basically a stone, okay, in the ureter, okay? And again, just like we mentioned earlier, this is kind of like what's going to be the cause of the loin to groin pain due to the autonomic nerves, which we said were T11 or T12? T12 to L2, okay? And then lastly, over here, we can see in the KUB contrast. Over here you can see, and it's kind of like when you inject a contrast or a fluid, and so they will appear. You can see the calyces over here, and you can see the ureters moving down as well. And it's important to note also that the fact that there are gaps between the contrasts it's normal. It's not due to anything. It's just due to the peristaltic waves. And so there's no obstruction here. Like all of this is like normal. Because like we said, the ureter undergoes peristalsis. Okay? And then lastly, we have the ureter histology. Okay, so the ureter, inshallah, it's nothing too hard. This is the only image that you need to know for the ureter. Like if you see this, like you should know that it's the ureter. Okay, its identification point is the fact that it's star-shaped. Okay, and it's due to the mucosal foldings. Just like the kidney, the ureter is also retroperitoneal, and like we said, there is peristalsis of the urine. So there are three layers that you need to know for the what's it called? For the ureter, we have the mucosa and the muscularis and the adventasia. So going from inside to out. Okay. So first we have the mucosa, which is made of urothelium, which is basically transitional epithelium. Okay, as well as fibroelastic connective tissue. Okay, so we could see that here in this area. Okay, the transitional epithelium. And then over here on the outside, just outside of it, we have the fibroelastic connective tissue. Okay. And then we have the ureter histology, sorry, we have the muscularis. In the muscularis, it's different in different areas of the in different areas of the ureter. Okay, so in the proximal two-thirds of it, you're going to see like the muscle foldings or the muscle orientation. You're going to see it as inner longitudinal and outer circular. Binama in the distal area, you're going to see it as LCL, inner longitudinal, outer circular, and outermost longitudinal. Okay. And then lastly, we have the adventasia. Any organ is going to have like a layer of adventasia. It's like the outermost layer of it, basically. Um, yeah, and that's it, I believe. These are some extra pictures. Okay, and that is it for my portion. Do you guys have any questions about the ureter so far? Inshallah, it's nothing too hard either. You don't need to know much about it. Um, Basically like the constriction sites and this histology slide, the clinical application of its of renal colic pain. Um, yeah, do any of you guys have any questions? Anything that you want me to explain again? خلاص, okay. But if you guys have questions at any point in time before your exam, please feel free to reach out to me. Now I will be passing the floor to Sattam, who will be taking over. Thank you guys so much. And yeah, again, if you have any questions, please feel free to reach out. Sattam, the floor is yours. Sattam, if you're speaking, I don't know if it's just me, but I can't hear you.
Okay, thank you, Durar, for that explanation and welcoming me. Again, if you have any questions, feel free to stop me, say it in the chat, or just let us know over text. We will be happy to explain to you guys. All right, so let's go to the bladder. Can you see my screen?
Yes, we can.
Okay. So like we all know, the bladder is a tetrahedral like this, meaning it has triangular shape, and we'll get to each base and apex in a minute. But what we need to know, how do I get this chat out of here? Sorry about that. Okay. It lays in front of the pubic symphysis. It is a subperitoneal organ, which means the peritoneum doesn't actually cover it. It goes around the uterus and lines it. And can you see my cursor?
Yeah, we can.
Perfect. Okay. So in males, it would be anterior to the rectum, but in females, it would be anterior to the vagina and uterus and cervix as well. On a cadaver, this is what it would look like. And in this case, obviously, it's a female, and they could ask you something like this: like if you see a uterus, just don't get it confused with the bladder. And this is the pubic symphysis. Okay, the external features of the bladder: you have 4 surfaces and 4 angles. Obviously, you have the superior surface. You have 2 inferior lateral surfaces, which you can only see one on this picture, but just imagine the other side of it. And the bladder neck, which is what the urethra comes or is continuous with, comes out of these 2. And then the posterior part, which is called the base. Where is it? There it is. I need to get this chat out of here. Okay. Now let's move on to the angles. One, you have the apex, which is continuous with the median umbilical ligament. And it is the remnant of the urachus. Again, you could get embryology, so just be careful with that. Again, we said the neck is continuous with the urethra. And the posterior lateral angles are the entrances for the ureters, which will be even more important in a second. But what's the significance of the apex? They could ask you, what's the clinical significance of the median umbilical ligament? Well, if it doesn't close fully during development, or if it opens for whatever reason, you could get a urachal fistula or a urachal cyst, which is where urine kind of leaks out of the umbilicus. Okay, now let's take the relations of the bladders, or the bladder, or what is posterior, anterior to it. And this depends on the gender as well. So in males, the base or the posterior part is related to the seminal vesicles and the ampulla of the vas deferens. These are the seminal vesicles, and this is the ampulla of the vas deferens, these 2. And The neck rests on the prostate. In females, the base is related to the cervix. So behind it would be the cervix and the anterior vaginal wall. And the neck lays on the superior fascia of the urogenital diaphragm. That's not really that important, but just knowing that they don't have a prostate, obviously. Okay, the internal features of the bladder. This is important. They asked us, I think, about this in our OSPE. So what are these folds called? Does anyone know? I mean, it says it right there, but any answers? Okay, exactly. But does anyone know what their purpose is? Distension. Perfect. Yeah, for more space when urine is filling it. Then there's a trigon. And this is just an example of the left ureteric orifice. Obviously, there's the right one here, but just make sure you can point it out if you see it on a model. And the bladder wall is made of the detrusor smooth muscle. We'll get into it more. Specifically, let's go look at the trigon. They could ask you about the boundaries of it or what forms it basically. The trigon extends from the left ureteric orifice to the right ureteric orifice to the internal urethral sphincter right here, which is labeled 7. And that's what makes up the edges of the triangle of the trigon. And it's the area on the bladder or the inside of the bladder that doesn't have rugae. So what's the function of it? Well, it senses stretch and kind of relays the signal to the brain when you need to micturate or urinate. And it's a common site for infections, but they're not going to probably ask you about that. Trigon embryology, this is important. Unlike the rest of the bladder, which is from the endoderm, the trigon is from the mesoderm or the mesonephric ducts, which is where the ureter is from. And since they're continuous with it, they kind of are made from the same thing. They could ask you about this embryology in it in OSPE. All right, let's look at the blood supply. This is a lot of yap, I'll be honest with you. All you need to know is that the superior vesicle is the main supplier. Yes, it supplies the fundus and neck, but I highly doubt they'll ask you about that. The inferior vesicle, though, this is what they like to ask, is often replaced by the vaginal in females, okay? So if it's a male cadaver, it could be the inferior vesicle, but if it's a female one, it could be the vaginal artery that supplies the posterior inferior bladder. There's also the obturator arteries and the inferior gluteal arteries. Okay, so remember how I said it's a infraperitoneal organ? That means it's not covered by the peritoneum, but it does wrap around it, and this creates these pouches. And the clinical significance of this is that if someone has any leaking or fluid buildup in their peritoneum, if they're standing, it'll accumulate at the lowest point due to gravity. And in males, this lowest point is the rectovesical pouch, or the pouch between the rectum and the vesicle, or the urinary bladder. In females, though, it would be the Douglas pouch or the rectouterine pouch, because that's the lowest in females. And again, males don't have a uterus, so it's not going to accumulate there. But that's while standing. While flat or supine, it's the hepatorenal recess, but they're not going to ask you about that either. Again, if you're a nerd, you can memorize this. The gap between the bladder and the pubic symphysis is the space of Ritzius. These are all just like different places fluid can accumulate in the body. Okay, what is the innervation of the bladder? So we know that it's both parasympathetic and sympathetic. The parasympathetic specifically, because we remember craniosacral for parasympathetic, is S2 to S4. And rest and digest for parasympathetic, or how I remember it, P for P, parasympathetic, makes you want to go to urinate. So it'll contract the detrusor muscle and relax the internal urethral sphincter. The sympathetic, on the other hand, is if you see a snake, your fight or flight response, it'll relax the detrusor, so it won't be pushing the urine down, and it'll constrict the internal urethral sphincter. And the somatic, but again, like we control when we urinate, right? So it's not the internal urethral sphincter that we control the external one, which is part of the pelvic floor. And that's controlled by the pudendal nerve. So if you lose control of the pudendal nerve, or if it's cut for whatever reason, you can't control your urination. Okay, let's go on to the histology. Again, 3 layers: mucosa, muscularis, adventitia. Mucosa, we have the urothelium, which is the transitional epithelium, because does anyone know why it's called transitional epithelium, by the way? Exactly. The shape can transition kind of from its normal dome shape to squamous-like shape whenever it's filled to basically have more capacity. What you need to know is that they're folded into rugae, 5 to 6 layers of the urothelium. Sometimes it's binuclear, as you can see over here. The surface cells are dome shaped, and the lamina propria is fibroelastic CT, just like pretty much everything else. Let's move on to the muscularis, though. Remember LCL, same thing here. It's inner longitudinal, outer circular, then outermost longitudinal. So don't forget that. And they could take a like point to these and say, what are these? You have to say rugae. I think we had this on our OSPE as well. And it'll actually, I think I have a question on it, so I'll stay quiet for now. Lastly, the adventitia. Again, the fact that it's infraperitoneal means that it's sometimes covered by peritoneum and sometimes not. So when it is, it's called serosa. Okay, that's what it's covered by. But anywhere else, it's covered by CT or connective tissue. All right, time to lock in. Which bladder of these is full? And give me 2 reasons why. It's a 2-mark question. A, okay, it's flat. Can you be more specific though? Yeah, it's flat. Okay, perfect. But what I want to hear is, yeah, it's only 3 layers. That's a good one. I didn't even put that. Is that the rugae disappear? Okay, don't forget that one. Yeah, it's squamous, less layers. All of you are correct, mashallah. Okay. Next question. What identify the structure marked by the green arrow right here and mention its clinical significance? I don't know why this is A and B. Green is the median umbilical ligament. Perfect. Does anyone know what structure 10 is, by the way? Bladder. Perfect. So just don't get it confused with, like, they'll point to 2 and that's the uterus and then you'll get it wrong. So just make sure you know female anatomy compared to male anatomy. Perfect. The clinical significance is urethral fistula or cyst in case it doesn't close, where urine will actually leak out of the umbilicus. Okay, this is a little bit of a more difficult question. So whoever gets it, I'll give them like Kinder Bueno or something tomorrow. I don't know. I'll give them the identify the structure. Label 10, we already did that. But B, give me 2 of its posterior relations and both of the sectors. I mean, just think about it. I mean, you can kind of see it right here, but like what would be behind this in males versus females? Male seminal vesicles and ampulla of the vas efferents. Perfect. Uterus and rectum and female. Exactly. But I would personally, like if I got this exam, I would say, I got this on the exam, I would say uterus and cervix because it's kind of like not exactly behind the rectum for females. But for males, yeah. I'd say this is the best answer. You're the vesicle and the ampulla of the vas efferents. All right. Last question for the bladder. What is this area? I mean, you can see the rugae, so you know it's the bladder. Cystic trigon, perfect. What is its embryological origin? Mesoderm or mesonephrectum, perfect. Quick question, what's the embryological origin of the rest of the bladder? Endoderm, perfect. Good job, guys. Inshallah, I got this. All right, let's move on to the urethra. Okay, so normally the male urethra is 15 to 20 centimeters. It's much more complex. Like the female urethra, as you can see, it's only, I think, 4 centimeters. Yeah, 4 centimeters. And it's closer to the anus, which makes it more prone to UTIs. They could ask about that. It's also more prone to UTIs in general, like with catheterization, because the bacteria only has to travel a shorter amount of distance. The internal urethral sphincter in males is more developed, and that's just extra muscle when they need it for ejaculation. And the external urethral sphincter is equally as strong in both. What's UTI? A UTI is a urinary tract infection. So you could get infected by like bacteria going up into the urethra. Let's look at the sphincters a little deeper. The internal urethral sphincter, like we said, it's innervated by the autonomic nervous system. Remember the mix of sympathetic and parasympathetic that I said? Basically, just remember sympathetic, you're in your flight, you don't really want to urinate. But when you are in the parasympathetic or rest and digest, you could, yeah. The urethra is continuous with the neck, of course. And the external urethral sphincter, we said, is innervated by the pudendal nerve, but specifically the perineal branch. Okay, just keep that in mind. All right, now let's look at the parts of the male urethra. One, you have the pre-prostatic urethra. Sometimes the doctors think this is a part, sometimes they don't mention it. If you get this, it might be an MCQ even. If you see pre-prostatic, it's the shortest. Okay, that's all you need to know about it. The prostatic urethra, which is the second part, is the widest one. And it contains two things that you need to know about. This utricle right here, the first kind of dimple, well, three things, but this first hole is the prostatic utricle. These two under it are the ejaculatory ducts, okay? And then there's a bunch of prostatic ducts all around, and this is just whatever the prostatic fluid or, whatever it's putting in there is going in from. Now, the next part is the membranous urethra, which is right here. It's the shortest and the most narrow and delicate part. So this could be asked, and what's the most commonly injured part of the urethra, especially during catheterization? The membranous part, because it's so delicate and narrow. And it's surrounded by the external urethral sphincter, which is the part that we control. And an important thing to know, I don't think it's labeled here, but the bulbourethral gland sits at this level, but it doesn't open at this level. Okay, so just remember, commonly injured during catheterization, shortest and narrowest. It's the second shortest if you consider the pre-prostatic. If you don't, it's the shortest. Okay, the last part is the spongy urethra. Let me put you here. It's split into the bulbar and penile, depending on. I'll show you on a different picture. It's easier to see. It's the longest part, and this is where the bulbourethral glands open into, which are right here. These are the glands. It has two dilations. One, the navicular fossa right here, and the first one, which is the bulbar fossa. Let me show you on a different picture, maybe. Yeah, right here. So the spongy urethra, right here, it starts from this little horizontal line, but as soon as it dips down, that's when we call it the penile part of the spongy urethra. But here, it's the bulbar part of the spongy urethra. So if you get an exam, you could say both, but maybe just stick to spongy and then, because that's the main one. And also you should kind of know how to read this one, because like we said, this part is kind of wide. And what was the widest part of the urethra? Membranous. Yep. No. Prostatic, yeah. You almost got me. You answered so fast, I thought you were right. My bad. The membranous is actually the shortest if you don't consider the pre-prostatic, and it's the narrowest. Okay, now let's move on to histology. It's said in your slides that it's stratified columnar epithelium, but I remember Dr. Ani specifically told us it could be pseudostratified, but for OSPE, stick to stratified columnar. And then obviously it has its lamina propria. You don't really, like everything has lamina propria, like it's mucosa. Let's have a quick question. Which part of the urethra is indicated by the arrow? And try to be specific. Spongy or penile? It is spongy, but it's the bulbar part. Because, like we said, the penile part is only when it's actually like the external or like it starts going down. Okay. The bulbar still isn't visible, I guess. Okay, name the type of epithelium in this structure. Stratified columnar. Okay, good job, guys. Next question. Identify the structures A and B And which part of the urethra is most susceptible to damage during catheterization? I'll be honest, A isn't really obvious here, but just imagine by the space or like the location. A, bulbar fossa, B, navicular. Perfect. Exactly. And what about the most susceptible part of the urethra to be damaged? Membranous, exactly. And that's number 3 right here because it's the shortest and narrowest. All right. Now you're probably going to get a picture like this in the exam. I know we did, and basically no one got it right, but inshallah, not you guys. Identify the structures A and B. A is utricle. Yep. Do you know what B are? The two right here are? Ejaculatory ducts. Exactly. All right. Almost there. Just the prostate and CTI left. Okay. So moving on to the prostate. It's a walnut-shaped gland found only in males, and it rests directly below the bladder. In fact, the bladder actually leans on it. What are its functions? It creates prostatic fluid, and it helps with ejaculation because it actually has some muscle in there. So generally, you could say it's for reproduction. What are the prostatic zones? Now, I'm not going to delve into prostatic segments. Let's just stick with zones for now. It's more high yield. Okay, the transitional zone first. And what I need you to remember is that the transitional zone has or it surrounds the urethra, okay? Which means it's a common site for BPH or benign prostatic hyperplasia. And that's when the transitional zone or the prostate cells kind of grow bigger and they compress the urethra. And then the usually older male can't urinate easily. And if someone has BPH, now I'm sure Dr. Ra'ataf told you this, if someone has BPH, it'll feel like, touching your nose. But if someone has prostate cancer, it'll feel like touching your forehead. So that's what we like in words. If it says firm texture, always think of BPH. Next, the central zone, which surrounds the ejaculatory ducts. That's all really it does. Then you have the peripheral zone, and you could remember it. Peripheral zone, P for prostatic cancer. Okay, and again, it'll be a hard texture. So make sure you read carefully what it says. If it says hard and nodular, it's prostatic cancer. If it's just, I guess, firm or tender, it'll be BPH. Now let's look at the lobes, which is different than the zones, but just try to memorize them together and link them. So they separate it based on whatever's entering or exiting. So the urethra entering separates the anterior lobe from the I guess the medium and the posterior lobe. Okay, the posterior and the median is separated by the ejaculatory ducts. Again, same thing. Posterior, P for P, prostate cancer. The median lobe is susceptible to BPH, which is the transitional zone when you call them zones instead of lobes. Okay, prostate histology. This is a young male's prostate. You could see, number 1 is the acini, which are the ducts and whatever makes the prostatic fluids. And 2 is the fibromuscular stroma. It's fibrous tissue plus muscle for the contraction for ejaculation. And of course, you'll have collagen in there. Now, this is an older person's prostate. And what you'll see here is the exact same thing. You'll have the ducts, you'll have the acini, you'll have the fibromuscular stroma here labeled 2. But within these acini, you will find something called corpora amylacea. And these are just solidified stones, kind of. So if you see it, you'll know this person's probably very old. Okay, what type of epithelium does it have? It has pseudostratified columna. Okay, so I guess technically the urethra also does, depending on which slide you refer to, but just make sure you remember this because we were asked about this as well. All right, moving on to the questions. A 72-year-old male presented with a history of difficulty urinating on digital rectal exam. Because prostate was enlarged and firm, which of the following zones is most likely affected? A. Okay, can you name the zone? Transitional. Perfect. But I think it's B, not A. A is D. So you want to know what A is? Exactly. And that's because the ejaculatory ducts are going into it. It's the central zone. Now, next question. Same exact case scenario, pretty much. But he says it has a hard nodular texture. In this case, which zone is likely affected? C, exactly. Which is the P for P? Peripheral, exactly. Or if they're asking about lobes, posterior lobe. Again, just make sure you read the keywords. Okay, which of the following is an older prostate and why? Bonus points if you spell it correctly. They're not going to be too, caring about how it's spelled, but yeah, corpora amylacia. I don't think any of you spelled it right. No, actually, you did. Okay, good job, guys. Yep, you can see the corpora amylacia in the acini. All right, lastly, sectional anatomy. I am going to just tell you how to study this real quick because it's very simple and they always ask one question on it. Basically, the way you know or the way you answer these questions is you need to know what level you're on based on what you see. So always just link it. Okay, I see this, therefore I'm at this level because that's what they're probably going to ask you about. And again, remember how we said the what's it called? The right kidney is lower. That's why we could start seeing the left kidney first, right here, compared to the right one. Okay, so at level T11, we haven't really crossed the diaphragm yet. I mean, we have at its higher ends, but we still see the crura right here. We see the aorta, we see the IVC, nothing renal related. So let's just go one step further. Did they ask about the level? Yes, yes. And I'll give you an example question of like something they'll probably ask you, like anything similar to it. So now that we've crossed the diaphragm, we're at T level, T12. We can see the aorta exiting its hiatus, all that good stuff, stuff we already studied. Obviously, we see the kidneys. I don't think we need anything else here. This is still the IVC. All right. Same thing, same thing. But T12 lower border, you can see it's actually crossing the hiatus. Obviously, this is the stomach. I don't think they'll ever ask you about like liver, stomach, when it's not really, you're in renal, but it is good to know. Do I have to say upper and lower border? I highly doubt that. No, because it's the same thing. It's not like they even added much. Like you could see same exact thing. The L1 upper border. This you don't really have to say, oh, this is upper or lower border, but it is important to know what you can see here. Okay. So how do we know that we're at L1 level? Can anyone tell me? Because this is the type of stuff they'll ask about. Like, oh, how do you know that we're at this level? Or this is what they're testing on. Exactly, the hilum. You can see the kidney hilum, the renal hilum. Next level of L1, lower border. You also see one more thing that indicates you're at L1. Can anyone tell me? It's right here. Again, yes, the hilum is visible, but more specifically, remember how we said what comes out of the aorta, or specifically a paired visceral branch of the aorta at L1 level? No. Yeah, but that's not a paired visceral one. It's the renal arteries, level L1. Because you can't even really see the SMA here. Yeah, but you can still see them. Like, yes, they're L2, but because you're at the lower border of L1. How is 11 diaphragm? Let me show you. this is the diaphragm right here. Because again, you're taking a section of, like, look at the top right for reference. You're taking a section of someone and you go down till T12, which is where the diaphragm ends. So you'll still have diaphragm above it, but it's like the end point is T12. Where did we stop? Okay, L1 lower border. Again, you see the renal arteries and the veins as well. Yes, they're T12. That's when they come out, but if you could see them going to the hilum, خلاص, you know you're at L1. If you could see them coming out of the aorta, then yes, I'd say you're at L2. What else? Is the lumbar vertebrae correct? This labeling, it should be correct, yeah. I mean, if it isn't, you guys can appeal it. But we had the same exact slides. They got us a picture. It's a mistake. Okay. Well, I guess you guys got a free appeal question, inshallah. I meant as a justification. I'm not really sure. Just make sure you memorize exactly like what it says here, because they're not gonna like go out of this for the mark scheme as well. Okay, at L2, do we see anything new? Or is it just same old, same old? Pretty much. I mean, this is where the renal arteries should be coming out of, but I don't know if you could see them here or maybe at a different level. Nope, for some reason it's at L1. All right, now at L3, you start to see this show up. I know it says it right here, psoas major, but it's good to know because they could get you a picture of like an abscess here and it'll look a little bigger on one side. And that's, I think they also asked us this for our OSPE, so just make sure you know where it is. Next slide, same exact thing. Okay. Again, you see the psoas getting bigger as you go down. You see more of the peritoneum, the mesentery, not really important, not your objectives. Okay, for the female tract, does anyone know what this is right here? No. Dr. Akram didn't come to you guys with the... No, never mind. Okay, it's not important. It wasn't even part of your objectives. Okay, obviously this is the uterus. Just they could get you a picture of this, and their main goal is to confuse you between the uterus and the bladder. So just make sure you know where you are based on. Like this is the rectum. The uterus lays on top of the bladder. Next, you have like a more deeper picture, a lower one. Now you can actually see the bladder. Okay, and 17 would be the vagina or the anterior wall resting on the bladder. I mean, there's nothing much here. They're not going to ask you about any of this. This they could. Again, we already seen this picture before. You guys answered perfectly. MashaAllah alaikum. This would be the uterus, and this would be the bladder. 22 is the pubic symphysis. That's pretty important. Is there a question? Okay. All right. Now for the male tract, good thing here, you don't really have to confuse yourself between the uterus and the bladder. The thing posterior to the bladder, just like we studied earlier, is the seminal vesicles. And it has this like almost like circular trypophobia shape, and that's how I remember it anyways. This would be the prostate, like this whole thing. And inside, you'd obviously see the urethra. And I highly doubt they'll ask about this, but this is one of the ejaculatory ducts or the ejector duct. This is just another angle of the exact same thing. Like just memorize. My advice for you guys for the CT section is memorize these levels. If there is a mistake, which makes sense, honestly, now that you pointed out, because why would we see the renal arteries at L1? Maybe ask your doctor about it, but just memorize what you could see at which level. Okay? Because they're probably going to be like, okay, look at this right here. and tell me what this is and tell me what level we're in. That's how they like to ask about things. And it should be an easy free 2 marks. Now, same thing goes for CT scans. It's the exact same thing. It's just going to be black and white. I highly doubt they'll like ask you anything that deep. Same exact concept, guys. You can actually, in this case, see a little clear, like the visceral vessels coming out of the aorta. It just depends on the slice, I guess, or like the section they take. Again, also try to know the levels based on what you could see. Like here, you could see L1, like you said. Someone said the SMA. Here you can see it. Okay, so good job, whoever said that. L2, obviously you can see the renal arteries and the hilum. Okay. Finally, I think this is the last question, last thing we have. And this is how they like to ask questions. What level is this cut taken from? And explain how you came to that conclusion. L1. Okay. How did you come to that conclusion? Like list 2 features or... Okay, hilum. I agree there, but the renal artery is seen, which is L2, so that's... Yep, exactly. Perfect. You guys are all correct. Left and right renal vein or artery. All right, so that's it. If you have any questions, can you say L1, L2? I would stick to what the slide says, even if it is a mistake, because at least then you have, grounds for what you put. And specifically because you can't see it coming out of the aorta exactly, which I mean, you kind of can. Like, I'd just stick with the slides, unless the doctor says something. Anytime. All right. Thank you guys so much. If you have any questions, feel free to reach out to any of us, our numbers or our emails. And do you have anything to say, Durar? No, I think we're good.
Yeah, I just wanted to say thank you again, guys, so much for joining. Inshallah, ya Rab, تستفيدوا. Inshallah, this was beneficial for you guys. Again, like Sattam said, please feel free to reach out at any point if you guys have any questions regarding the OSPE. Hopefully this will be enough. And yeah, thank you guys for joining, and thank you, Sattam, as well.
All right. Thank you.